Can everybody hear me okay? Yeah. Yeah. 7:30 at the back. Yeah, basically, I'm going to do a quick advertorial, and then I'm going to witter on a little bit about a passion I have. My Amigo, the system is upstairs. You can see it. Have a look at it. It's a monitoring system developed basically for use in care and looking after people with dementia and learning disabilities and other cognitive impairments. And it's about monitoring them, collecting data about them, about their habits, and doing some risk management. But basically what I wanted to talk to today is about the concept of collaboration and how collaboration can actually result in what I'd call the bigger picture of how social care and healthcare can actually start communicating together. Now, I'm sure a few people will disagree with me, but here we go. So we were actually born out of collaboration, been there, seen it, got the badge, got loads of people who input into it. They all had their own views. But this, if you notice, actually, there's only about one organisation in there that actually has anything to do with social care at all, and that is Jackie Poole, who's an occupational therapist. The rest of us were a bunch of technologists and businessmen who fundamentally knew very little about the area we were getting into, but we learned pretty fast. And the whole issue was that actually we had some validation to do. And I'm going to keep on about validation because in collaboration, validation is actually key to what you do. Once you've built something, you haven't finished. Collaboration continues along the way. And you continually validate and you continually learn. You may not actually change the technology, interestingly enough, but actually the way that technology is used actually could be could be the key to the success of a project, for example. So on here, fundamentally the idea came out of a care home sort of scenario. I want to look after people with dementia. I want them to be able to move around the living space where they're capable of doing, but I don't want one-to-one elbow care. What I want to do is I want to allow them to go, and when they get into difficulty, I want a system, a piece of technology, to tell my staff that intervention is required. That very simply was our concept. Now, we started off with this in about 2007. We had 2 years of playing around with it. With customers who actually paid to play around with it, interestingly enough, which is quite a challenge, I have to say. But basically, that's what we did. But what I wanted to say was we continually validated. We actually finished up with a situation not a million miles away from here, up in Stafford. And it's worth actually mentioning this. We started about 5 years ago talking to Stafford County Council. And it was about whether this thing we had invented actually had any value to social services in Stafford. And at the time, the question was, thanks very much, very clever, like it, not sure where it fits. Now we continued, and if some of you will probably know him, there's a guy called Jim Ellum who operates out of Staffordshire, who's a telecare and commissioning manager. And basically what happened was, we had a situation where we did actually raise some funds out of CETA to actually validate, in this case, the use of the system in somebody's own home. Never thought of it, didn't think it was anything we could do, let's validate it. And Jim actually got involved with that, and we actually validated it in a number of areas. What was interesting, this was about using it in terms of people with dementia in their own homes who had a carer within their own living environment. And what actually happened was, as a result of that, something clicked with Jim in terms of how this thing could be used. And suddenly we became the training unit of Staffordshire Telecare, I think, for a while. And we went on the road, effectively, my colleagues and I. And it was really about teaching or learning from and educating various areas of the Staffordshire team. So we finished up with adult services. Is it going to be a value there? Yes, it is, but not quite sure yet whether we're ready for it. We went to care homes that was facilitating meetings, got feedback, assisted living, very much a two-way exercise. Telecare teams in Stoke, etc., that we got shown to. But what was interesting was actually the first use of it in a home, somebody's own home, was actually in children's services. And somebody went, hang on a minute, high-end autism, we have parents who are looking after children 24/7, they sleep outside their room, they sleep in their room, they never leave them. They are absolutely stressed out beyond belief. And what the idea was actually if you had this monitoring system for the child, the parent could step back. And lo and behold, something that we hadn't thought of was that actually the carers could benefit from this exercise. And in this particular exercise, the carers become less stressed, therefore the need for social care from outside becomes less. And if you follow the logic of that, that could apply to dementia and other learning disabilities as well. So actually, the knock-on effect was we thought we were helping the child, but actually we were actually helping the parents who looked after the child. And strangely enough, the children changed their habits. High-end autism children used to go and turn on the taps, flood the bathroom, trash their sister's bedroom. Suddenly it stopped because mum wasn't hanging around. A bit bizarre. But then we moved on, another education exercise. Jim was very keen about actually seeing the language of social care and healthcare coming together. The concept of personalisation, the concept of well-being. Well, what does it mean? It's not necessarily somebody's temperature's high. It could be the way they feel. And you can't always understand somebody who has cognitive disability, understand how they feel. They actually express it very often, and this is where our system came in the way that they behave. And the way they behave actually is that potentially, if they've got a problem, UTI, they're depressed, guess what? They don't move around so much. They don't necessarily go to the same rooms. They change their habits. They don't go in the garden. Now, you don't get that from taking their temperature or their blood pressure. You actually get it from observation. Now, you can observe in a number of ways. One, you could observe by following all the time, and people with dementia don't find that very encouraging. In fact, they can be quite aggressive toward being followed. Or you can actually do it remotely. Now, they're then able to do exactly what they're capable of without intervention until it's needed. And that was very interesting. The NHS at first didn't get this because it was almost, in case there's anyone here, it was almost like holistic medicine. You know, we were talking voodoo, really. Dangerous stuff, mobility and where people spend their time. How can that actually reflect their health or well-being? Still, we kept going and persisted. And what was interesting, gradually, what Jim said was, if you have this sort of technology that's able to monitor somebody for their condition of well-being, it applies to everywhere they have their healthcare delivery. If it's in their home, if it's in assisted living, if it's in a care home or it's in a hospital, it's all the same. And they will behave in a certain way under certain conditions. So actually, you can now actually have a doctor, a GP, who is diagnosing somebody for a condition, giving them medication. Then what happens? They've got dementia, they can't tell you how they feel, but actually, funnily enough, they've slowed down. They don't walk as much as they used to. They don't go into social areas. Well, hang on a minute, what does that mean? Take them off the medication. Oh, funny enough, they've started walking around again. They've started socialising. And it's not the obvious things that, you know, you can ask people with learning disabilities or dementia or any other cognitive impairment. They don't necessarily have an answer for you. And it's a very difficult thing to diagnose. However, in social care, this sort of behaviour, and in particular care homes, they're quite used to people with dementia acting in rather aggressive ways or passive ways, or, you know, but they can't articulate to a professional GP or nurse what it means. They can say, oh, they're a bit fuzzy or they're a bit aggressive. And that's basically when it gets down to it. What we finished up with the NHS in South Staffordshire is that they picked up on this point, that actually if somebody comes into hospital, they live there, right? Whether it's for a week or 3 months or whatever it is, they're living there. So actually, we have to improve the lived experience. The lived experience is not improved if I come into the hospital and 24/7 you watch me. You walk around following me. Guess what? I'm going to get aggressive about it. So what they've done is they've actually said, well, no, we're going to step back. We're going to let people not have one-to-ones. They could be 1-to-3s, 1-to-4s, but actually I will get a message to say when I need to intervene because they've gone somewhere that I need to know about, or they haven't gone somewhere that I need to know about. And actually, significantly, not only is it seen improvements for the individuals in particular areas, and particularly for South staffs in learning disabilities, the interesting thing is it actually has a fiscal benefit. Because to have somebody following someone 24/7 unnecessarily, most of you will probably know, is quite expensive. But it doesn't have to be. And actually, the life of the person could actually improve by being allowed to go to the workshop on their own and be left there all day if necessary, as long as they're fed. And that's the important thing. But again, it's validation. Does it work? Does it do the job? That's it. Okay, thank you.